Okie dokie, that's coming up there clearly. Is it Christy?
I can see it from my end and hopefully everybody else can.
Yeah, perfect. Excellent. So thanks everyone so much for the invitation to come along and have a chat with you all today. Super excited to be speaking to such a large group of fellow massage therapists today. And I saw from the chat this morning that people are calling in from all across the lands, which is awesome. I'm based in the Blue Mountains in New South Wales. I would like to acknowledge the traditional owners of where I call in, which is the Darug and Gundungara people. I'd like to pay my respects to their elders, past, present, and those that are emerging. So it's been a bit of a journey for me getting to this point here, working as a general manager for the Pain Revolution. My journey started when I started experiencing persistent pain. And so this went on for years. I think very similar to a lot of people. I saw every single clinician under the sun, got all the scans, got all the tests, and none of it was helping me. And I really started to lose hope. I guess for a long story short, for me, in this moment of hopelessness, decided to give everything up. So I left my fast-paced job, I left my partner, I left my inner city life, and I moved out to the wilderness in New Zealand. So there's a little picture here of Sutherland Falls, which is on the Milford Track. I know we have some folk from New Zealand calling in. And what happened for me was really unexpected, and it was almost instantaneous to going out there. My pain went away. And this was after years and years of trying everything and nothing helped. And this didn't make any sense to my understanding of pain at the time. So at the time, I understood pain to be related to tissue damage. And then, so how could it be that I could change my context and my pain goes away? I went on to learn that this makes sense with the contemporary understanding of pain, and I'll go into that a little bit further for you guys today. But I guess this experience really sparked an interest in wanting to understand the human body more. So I went and became a massage therapist, worked as a massage therapist for 5 odd years, absolutely loved it, loved the opportunity to be able to be working one-on-one with people in that setting. But as I was working, I started to have more and more questions emerging. Why are some people responding while others aren't? And so I went on to study medical science and neuroscience with a quest to really have a better understanding around pain. I have subsequently studied population health and social change theory, really wanting to build out around how we can best create a pain care system. So that's a little about me, the problem. So pain is a big problem, and this idea of persistent pain is really huge. So 3.37 million Australians are currently experiencing persistent pain. And it's only getting worse. So here's a graph that came from the Australian Burden of Disease study. So in 2003, so this ranks conditions on disability adjusted life years, like what are the impact on people of these conditions. So 2003, we had back pain ranking in as number 4, and then in 2015, that's jumped up to be number 2. So what I see when I see stats like this is thinking we can and we should be doing better and something different with how we are caring for people who are in pain. I think it can be helpful to understand models of pain. And so models are really around trying to understand a really large body of evidence around science and pulling it into a cohesive way to understand how can we apply this into the work that we're doing. So a probably dominant understanding around pain, which is probably more formally dominant, was this idea that pain is around tissue damage. So if you have tissue damage, you have pain, and then if you treat the tissue damage, then you treat the pain, and this is known as the biomedical model. But now there's lots of research that's emerging to suggest that we're actually not looking at the whole picture for a way to understand pain. and probably this idea that pain is influenced by biological influences, but also as well these ideas of psychological influences and social influences. And not much of a stretch of the imagination that this model is known as the biopsychosocial model. And so this is very much the model that we work within, and so we keep that in mind as we sort of step forward. I think it's also important to remember that these models are a way of trying to understand information and understand the body, but we are not decompartmentalized. So we need to remember that all of these have bidirectional influences, from the psychological to the biological, and the biological to the psychological. Okay, why do we need a revolution? So here we have this growing body of evidence talking about a biopsychosocial approach to pain. We have best practice guidelines, but for some reason, this isn't getting implemented into care and not having the outcomes then for people that are in pain. This is likely to be multifactorial, but one of the reasons that we think that this might be the case is that people don't have a contemporary understanding around pain. So what is the pain revolution? So the pain revolution is bringing together a whole group of people. So it's bringing together researchers, clinicians from a range of different disciplines, people with lived experience, peak bodies, and industry partners. And so we're really working to solve this problem around why are we not getting this evidence into practice? We're working towards this vision that all Australians have the knowledge, skills, and support to prevent and overcome persistent pain locally. So a lot of the projects that we do have a focus on rural and regional areas, and all of them really focus on building capacity. So building capacity in clinicians to be able to adopt and practice best practice care, and then also embedding capacity within people with lived experience to be able to have the tools and resources to be able to look after look after themselves on their pain care journey. Okay, so what is the role of a massage therapist in a pain revolution? So I've just sort of picked out these sort of three key themes. So the first is around building safety. Then we have making sense of pain, and then taking on the role of being a pain coach. So I'll jump into these a little bit further with you. So the first one, becoming a pain coach. So a pain coach can be anybody, can be a range of different disciplines. It also can be peers. So perhaps somebody has a lived experience of pain, and a pain coach is really around supporting somebody on their pain care journey. I really think that as massage therapists, we're really in a unique position to become pain coaches, because we have this time that we get to spend with people. A lot of other disciplines can, indicate that the time is a barrier for them. They have 15, 20-minute time slots. And yet for us, we can often be with people for up to an hour. The nature of massage means that we're able to also build trust with people, which puts us in a unique position to be able to support them on their journey. So what is a pain coach? So a pain coach needs to have a contemporary understanding of pain. The focus is on active and not passive strategies. And so by active strategies, this is something that the person themselves leads or engages in. So it could be talking therapies, it could be movement, it could be learning. And when we talk about passive, it's more around things that are done to them. So this could be pharmaceuticals, surgery, or manual therapies. And I think it's, the reason why we talk about active strategies being the focus of a pain coach is because these are the things that help with neuroplasticity and really helping to actively change the way people engage in their care. And Mary sort of touched on it before around, there may be a role for both passive and active, and there is no doubt in my mind that the passive aspects of massage are also very beneficial for people. It helps them to feel comfortable and safe within their body, getting some nice messages coming in through their body, and also having those points of care. So I think it's just for us to consider what's the clinical reasoning behind what effects we think we might be having and why on people in their pain journey. A pain coach understands different tools and strategies which they can use to help to guide people on their journey. And really it's about a shifting of the locus of control away from the clinician and to the person. So we're wanting to empower them to be the leader in their journey and helping them to build a self-efficacy to do that. Alrighty, so I guess fundamental to being a pain coach is around understanding pain. I've been studying pain and working in the pain care space for 6 years now, and I'm still every day learning more and more about it. It's extremely complex. There's so many different pieces to the puzzle. And when looking at the science, it can be quite overwhelming, trying to distill that down into a way that's accessible for people. So the Pain Revolution has developed a series of target concepts. So we did this through working with all of our stakeholders, including researchers, clinicians, people with lived experience. And we also had people, and then we also had some communication experts helping us to be able to communicate that. And I'm just going to touch on a couple of those target concepts today. So the first one is that pain doesn't equal tissue damage. And I really feel like that this is the key one for people to understand, to be able to shift their conceptual understanding of pain. So we can have tissue damage without pain. And so here's a picture of a guy who's been out surfing and he's been bitten by a shark. So there's many of these accounts where people actually haven't realised the extent of the damage until they're back on shore and they're seeking care, and then they see the blood and then they have the pain. So there's this period of time where they have this tissue damage without the pain. On the flip side, we can learn a lot from phantom limb pain, where people, amputees, actually experience sensation in the limbs that don't exist. So in this case, they're having pain without tissue there at all, but sort of it puts to, starts to paint this picture around that there isn't this direct relationship between pain and tissue damage. So there was a study done that looked at what are the implications for this in the clinic, and Mary touched on this in her talk as well, which was looking at imaging findings in pain-free adults. So this particular study looked at a series of different imaging findings relating to the back in pain-free adults, and this was what was found. So I'll draw your attention to disc bulge, because this is a common one that people will contribute to their back pain. And here what you can see is that at the age of 40, 50% of people who are experiencing no pain at all will have disc bulges show up on their imaging findings. And then we can see as we move through the ages that increases. So what we see here is that this might suggest, in fact, that these imaging findings are actually just a natural part of aging. And on that, there's similar studies done for other body parts as well, for the shoulder and for the knee. And so what are the implications for us to understand this target concept and how we work and how that helps people who are in pain? So I think firstly, it's around being able to help decrease fear and anxiety around their pain. And in particular, I think with how that relates to movement. So often people will be scared about moving because they'll feel pain and then they'll think, oh, I must be doing damage to myself. And so by understanding this, it helps to put movement back on the cards. And there pretty much isn't any system in the body that doesn't benefit from movement. It's critical to health, and particularly this is really important in a pain care recovery journey as well. So here, this then starts to open this idea that we can have this active recovery from pain. So we're starting to get a bit of a picture, okay, what pain isn't. Then we want to sort of understand better, well, what is it? And so what we know is that pain depends on context. And so context is all the information that's coming in at a time, what we're seeing, what we're feeling, what we're hearing. And that is also then comes together with our stored information, which might be previous experiences. The brain takes all of this information and it evaluates the info and has a look to see whether it thinks we are safe or whether we're in danger. And if it favours towards danger, then it's going to produce protective mechanisms to us to let us know that we're potentially in danger and that we need to change what we're doing. And so there's many protective mechanisms. So pain is one of those, but there's also inflammation and stiffness that are some other protective mechanisms. So let's have a look at some of the science which has led to the development of this target concept. So the first one is around what we see can influence our pain. So this is a study that was done on pain-free people. It applied a cold probe to people's hands and then also paired that with a light. So either paired that with a red light or a blue light. Now we would think that these lights probably have meaning. So when we look at red or we think about red, we can think of that as hot and dangerous and don't. And then with blue, it's more cool and safe. And what this study found was that when they paired the exact same stimulus with the cold probe with a light, people experienced more pain when they were shown that red light, which is associated with danger. So we start to see then here that what we see can influence our pain. What we smell can also influence our pain. So this was a study that was done measuring people's withdrawal reflex, which is another protective mechanism. So they were they got given an electric stimulus, and then that was paired with noxious odor, or in fact what it was a fart gas. And what they found with this study is that people had greater withdrawal reflex, so greater protective response when there was that smell of fart around. And then what we hear can also influence our pain. So this was the study that was done looking at stiffness. And one of the things they found was that there was a difference between perceived stiffness and actual stiffness. I think that that's an interesting note, but they also found then that when they applied this mechanical pressure, which is on the back, which is what's happening to this person here, and they paired it with the noise of a creaky gate, people had greater sensation of stiffness. So we start to see that what we hear as well then plays into our protective mechanisms. So what's the implications of this? This is the good news story, I think. This is around suddenly we have all of these care options available. When we thought that pain was only around tissue damage, then we needed to directly address that tissue damage to be able to help people. But here, now we understand that it's so much more broader than that. We have these psychological, we have these social influences as well. So we have some avenues that we can really start to have a multi approach to how we care for people in pain. We can help to get people to explore their context. And so this is around understanding in their life what could be some dangers or safety cues that may be coming in. The better that we understand what our safety and danger cues are, the better we can support ourselves. So this might be, look, I always know I find this situation particularly threatening. What can I do to be able to help it be less threatening for me? So that might be having, you know, Auntie Meryl always makes me feel really safe if I'm going to be doing this thing. How about Auntie Meryl comes with me? But really starting to have this, you know, as a clinician, to guide people through a self-reflective process around what are those broader things that are happening in those episodes of pain. and also for a person just to be able to start to get a better understanding of how they can guide themselves through. So I'm going to take a bit of a pause there on the science. So that was just a quick look over 2 of the 9 target concepts that Pain Revolution has. But I think what I really want to do is just take a pause and let's remember that care needs to be person-centered. And I can tell you that from my own experience and from talking with others in pain and from looking at the literature, this is really consistent. Persistent pain is a life-changing experience. For me, it came along, it turned my life upside down and broke it into a million pieces. The process after then was around trying to understand who this new me was and picking up the pieces and trying to build on the other side. There was a great study that came out this year that drew on the insights of people with lived experience that were living well with pain. And they talked about this idea of the rebuilding of self as a process of reoccupying self. And they had, they broke it up into 3 areas or distilled 3 themes from these insights of people with lived experience. The first one was around making sense of pain, wanting to understand what was happening to them. And really they hit on this idea that people need to be able to align what they're feeling in their body with what they're hearing from their healthcare professional. The second was this decision to go from patient to person. And what was the drivers in people deciding to do this was through a trusted clinician and also having a drive to re-engage with meaningful activities in their life. And so this is where the role of a pain coach can come in. They can help to make sense of people's experience, but they can also, by developing that therapeutic relationship, you can help to encourage people to step into that person rather than the patient role, and help to understand what is meaningful to them and how we might be able to use those as motivations to re-engage. And the third one was around flexibly persisting. And by this, they meant accepting that who you are may have changed or it has changed, but also that those people have the skills and support and tools to be able to cope with this new self. And it's also about re-engaging with life. So making, we're really wanting to encourage people to re-engage with those meaningful things in their life. So on this idea of making sense of pain, the literature suggests that people are seeking reassurance and validation with their pain care. And so really key to this is listening to people and deeply listening to people. We've just seen, this is a life-changing experience and people want to be able to share their story and be heard. I think one of the big challenges for pain coaches is around sharing this idea of a bicycle, a social approach to pain. A lot of people can perceive that the message is that the pain is all in your head, which is absolutely not the case. It's absolutely real, but the contributors are just probably more broader than we once thought. So, there's a big role to be able to validate people in their experience. Yes, your pain is real. And yes, this is a really huge thing to have happening in your life. In a process of deeply listening with people about their experience, you can also use the target concepts as education flags. And so by education flags, what I mean is, as you're listening to people, you might hear that there's some unhelpful beliefs that they have around pain and that they could vary, but then sort of make a bit of a flag to go, look, it might be good when the time is right that I revisit this particular concept around pain that might be able to help them make sense of their experience. And so then revisiting what the role of a massage therapist is in a pain revolution, it's firstly around building safety. So this is building a safe therapeutic relationship, and this is going to help to be able to support them in their journey. It's also around helping to guide them in an understanding around what might be danger and safety cues. You want to be able to make sure that you're using the right language that makes people trust and feel safe in their bodies and feel safe to move. Help people make sense of their pain. And I think this has two prongs. So firstly, it's around helping people to reoccupy self. But the other part is if people have a contemporary understanding of pain, then they're going to make better informed decisions towards active care. And then the last one here is around being a pain coach. And for that, really encourage people to dive deeper into your understanding of what pain is, what are different tools and strategies that you can use to help guide people through their journeys. Here's my email address here. Really happy for people to get in contact. Also jump on, check out some resources from the Pain Revolution, www.painrevolution.org. We've got stacks of opportunities for people to get involved. Really, this is a people-powered movement.
That was so great, Angie. Thank you. We're so lucky to have you for a little bit longer, just for our Q&A, because there are some questions coming in. And I think you going through the role of the massage therapist really helps take away that whole passive narrative that we get as massage therapists, that we're only hands-on. So thank you for that detail. Let me just bring up the questions. There are a couple there. So, Angie, what do you... I guess I'll just read the question exactly rather than try and interpret it. What do we do when a client believes it's your job to fix them?
Yeah, and I think that this is really dominant in the way people approach the healthcare system generally, and this is the way it has set up, come from a history of biomedical background. And I think that's also, it is challenging. And then the other part of that, it is challenging for people because it's really all consuming being in pain. And it can be difficult to come to people and say, look, this is going to be a really long journey and this is going to be most successful if you engage in this and I support you. It is a hard conversation to have. It's hard information to hear for people as well. So I think that this is really around building relationships, and it's also around building credible evidence. So you might not find that the first time you start having a conversation with people about pain that they'll be receptive to that. But it might be around revisiting it and looking at opportunities where there's sort of a crack in their story that might be able to invite that conversation a little bit more. And it also, yeah, so I think it's that process of building it. Keep planting the seeds. I'm not sure that anybody really has the answer around that, because it's probably more of a societal level thing around how what people expect from the healthcare system.
Mm. All right. There's another question here from Michelle. Are there any studies on people with impaired sensory, with impairments for vision, for instance, to see if their pain experience is different?
Yeah, no, it's a really good question. Not that I know of is the answer. What's really interesting about pain, so we have this theory, this model around the biopsychosocial approach to pain, but we actually have there are no measures that exist to be able to say what are the dominant influences or where are those influences are coming from. And then again, it's extremely personal as well. So it's personal to each person, and then personal to even what might be happening on a day, on what those influences are. So we have proxies for understanding. So for example, some of the studies that I talked about there, but we have no way to diagnose somebody to say, oh, you've got a, psychologically dominant pain condition. People, whenever they use terms like that, they're taking guesses, best guesses from information, but there's no way for us to actually diagnose that.
All right, thank you. Lee's got in here, in the future, will the Pain Revolution be accepting massage therapists to the LPE program? And please pick her.
Yeah, great. Thanks, Leah. I saw your name popping up there. Thanks for the Pain Rev shout out before. So I think I guess a bit of context for people, the local pain educator program, we provide scholarships to rural and regional clinicians to be upskilled to become pain coaches or local pain educators, to share this information in their communities. They go through a professional certificate in pain science and education, and then we mentor them and support them through that process. I absolutely agree, Leah, that massage therapists are really uniquely positioned to be great pain educators. The only barrier to that model as it exists is that it is the requirements to get into the professional certificate. So that's actually set by the uni, that you need to have an undergrad in health to access that. But we do have we are working on other models to make sure that we're not missing any clinicians out. So stay tuned, Leah, and of course you'll be at the top of my list.
I'm just going to keep going with questions until I get kicked off. I'm sure Beck's on there anyway. There's a question from Andrew. Are there any validated outcome measures to screen clients for social determinants of health related to pain prior to treatment?
Not that I know of is the answer. I'm sure that there are screening tools out there. I do always think that that's quite an interesting one. There was a study that came out this year that talked about social determinants of health for pain, and very similar to other health conditions. The sort of the classic ones around socioeconomic status, education levels. And so I think that they're things for us to be mindful of when we're looking at health and pain at a population level. So this is how we can target people. I often wonder whether the idea of social determinants of health is a great or complex representation of what the social is when we talk about the biopsychosocial model, and particularly how that relates at a clinical level or at a personal level. And I think then the social becomes so much more than those determinants, and it can be around how you engage with your community, how supported you feel by your healthcare professionals, how supported you feel by your family.
All right. Any timekeepers want to let me know how we are going? And if you haven't have a look, I think I'll throw in one more question. We've got one from Aaron. What areas do you think massage therapists need to know more to move from the biomedical understanding of pain to a person-centered understanding of pain?
What are the key? Probably that was reflected in my presentation, but I think for people key to people shifting from a biomedical understanding is around understanding that pain isn't directly related to tissue damage. And that's, in fact, such a hard one to break. And so even for myself, I'll often see myself in the way that I relate to myself or to others that are in pain, that I can see myself slipping back into that. We're trained that way. We have, broader systems that support that. And it seems quite compelling as well, as far as the experiences that we have in the body. So I would say that one's probably key, and then just keep being critical of your assumptions and keep thinking, why am I doing this in my clinic, and how does that relate to this new information?
Well, you won't see it because it's not your job, but gee, there's some positive stuff in the chat pod to say thank you and amazing and great presentation. And And I think you've already put your details up on the screen, and everybody will be sent that at some point anyway. And I think someone already put it in the chat pod anyway, your website. So
perfect. Yeah, so happy, any questions, feel free to reach out, and yeah, happy to chat further.